All right, we're in good shape to go ahead and get started with today's webinar. Really pleased and already excited by even the title, what is knowledge and what is the translation. This webinar is a joint initiative by the NMD4C, Neuromuscular Disease Network for Canada, and Muscular Dystrophy Canada. And so with that, I will turn it over to you, Cynthia.
Yes, thank you. So it's my great pleasure to welcome Dr. Keiko Shikako, who is an occupational therapist by background and an associate professor at McGill University. And she's the chair holder of a Canada Research Chair in Childhood Disability on Participation and Knowledge Translation. She also has a postdoctoral fellow in knowledge translation in policymaking for children with disability from McMaster University and policymaking in environmental design and accessibility from the University of Montreal. And her research focus on the promotion of healthy living and the human rights, of children with disability and knowledge translation, science and practice. Without further time, I will let Dr. Shikako present her conference.
Thank you, Cynthia. Thank you for the invitation to be joining you today for this seminar series. It's unfortunate that we on the webinar mode, we cannot see the other people, right? I realize it's strange not to see the audience, but I see we have 12 people in. It will be great to see you. I'll be happy to interact. I try to have my chat window on the side of my screen. So if you have at any point questions, or if you want to, you don't need to wait until the end. We will have hopefully a discussion time at the end. But if you have any questions, comments, or anything, let me know on the chat, and I'll be happy to chat. It's a pleasure to talk to you and to have bringing a little bit of a different perspective from what I've heard you had before. Of a more practical perspective of what's knowledge. And in terms of knowledge translation, I think that's the question I've been debating with, like doing research on knowledge translation and acting on knowledge translation in the past 10, 12 years. I think we've come a long way to understand, to come from a more strict vision of what is knowledge and the knowledge that we're trying to impart, or knowledge produced in the research setting or in the academic setting, and that should be translated or transmitted to a certain audience, to trying to understand knowledge more as something that is dynamic and that's produced by everyone around us. It's produced by our patients, by our research participants, by community, by society, and that's what we hope to, I think this understanding better what we call knowledge translation on itself would be good. So that's what I'll try to present to you today. So the first part then, when we're thinking of definitions, I think it's good to stop and think all the assumptions we have, right? So we work in health research, and most of you in pediatric health research or health promotion or as healthcare providers. And we have this challenge of understanding what is our conception of health, right? So the WHO, the International Classification of Function, Disability, and Health, has changed a little bit the understanding of health in the context of disability, to expand the scope to say health is not only, right, the absence of disease, which was the old definition, but much more than that. And then the knowledge that is produced within health is also changing. And it's also the way we see it, or the way we understand what this is, will have a dramatic impact on how we can act on it, right? Or what we can do about it, both in generating and promoting health and generating knowledge. So, for example, if I look for, and that's why it said that we cannot see, I thought it would be more of a traditional Zoom setup that I could see you all. But I was going to ask, maybe you can put on the chat, if I put this image, and I live in Brossard, I'm speaking from Brossard. So for those who are from Montreal, you know that this was a recurrent view. Now that's the old Champlain Bridge. And it was my daily commute. During the pandemic, it was amazing. amazing. There was no traffic. It was the best time ever in terms of traffic, but now it's all back. And if I put an image like that, what comes to mind in relation to health? If you were to say that, I don't know, can participants put messages on the chat?
Absolutely.
Okay. I was like, okay. So so if you can put it on, maybe put on the chat a few thoughts that come, how this image relates to health, or does it? What comes to mind when you see this? Pollution, bad for health, time, stress, thank you. Pollution, no active transportation, sedentary lifestyle, excellent. So those are exactly the thoughts that come to mind. Visual pollution as well, that's not pleasant, right? Although the view from the top of the bridge is amazing, it's not pleasant to see all the cars going on every day. Right, excellent. So those are a few great words that come to mind. Loneliness, yes, because you're there in your car instead of being on a public transit option, sharing spaces and interchanging information with others. That's amazing, great concepts. So when I put this other image, though, also from Montreal, what comes to mind then? I guess if you can add to the chat. And I would immediately say a lot of what you put active, right? So a lot of the outside exercise is good, outside time, more peaceful, active, prettier, ecological, definitely. The aesthetics, the visual pollution that someone had put before is gone, right? Like you see, even if you see in the city, you see nature, you see life, more peaceful, prettier, great. So this is exactly the types of concepts of health and health promotion that we would like to see translated, right? When we are working in health research, it's often too easy to get attached to the notions of health as disease, right? Or we're not healthcare providers, we are disease managers when we work in healthcare. And that is a conception that changes what we can do in terms of knowledge translation, because that's the knowledge we are built with, right? That's the built-in notion of health that we have. And that does not, if we accept to do that way, we often do not enlarge the scope of our action to consider those other aspects of health, even if it's easy and intuitive as human beings to look into those images and think of notions of health as more of this image here on the right than on the one on the left, right? We have diseases like you are here. We have networks that are grouped by disease types. We talk a lot about disease and we don't talk as much about health as we would like to, or as we say we promote. And that's important to consider when we are thinking of health promotion and knowledge translation. Art also is another element. So some of you put that like that there's a space, visual, so other concepts that are even farther removed from health promotion and the knowledge that we want to generate about health is the notion of aesthetics, options, right? Of what do we see and how do we perceive the spaces where we're living. Green areas, there's a lot of more and more research talking about the influence of green spaces in cities and the influence on health. So having parks, space for outdoors activity, and accessibility. Then when we transition to think about persons with disabilities, children or adults, how accessible is a city will have a large influence on the ability of people to enjoy full health, right, in this space, not only for those who use a wheelchair, but also for those, the parents with strollers, for the elderly, for the opportunities for intergenerational exchanges and knowledge transmission from one generation to the other. The ability of accessibility not only to hospitals, schools, and workspaces, but accessibility to leisure spaces as well. All of those points are essential for our understanding of health. And therefore, for the strategies that we'll think for knowledge translation as well, right? So what is health then, and what do we get it? So no longer the absence of disease, but if we look into the top 10 global causes of death, that's data a bit outdated from 2016, but that hasn't changed much. except for take COVID aside. But we know that the majority of the disease, the causes of death, so considering death the extreme of non-health, right, those dichotomous outcomes, life and death, if we consider health on those extremes, we know that the vast majority of diseases are preventable, right? And there are things that they're non-communicable diseases that we could do something that would prevent them. So health is really something we can promote. It's not something, it's not a given, but it's something that we can make things to prevent and promote. And we do know that, especially for children, but also for adults, for everyone, it's a combination of, for cardiovascular health, of exercise, good sleep, good nutrition, and good habits in general are associated with better health in this comprehensive way. But then if we look into low-income countries, for example, we have more communicable diseases as the top causes of death. And then we see that is still something we can prevent, but it depends a lot and largely on where you live, and then what are the policies in place, what are the realities of the ecosystem around, what are the options of the healthcare system. So we know that the death or health promotion initiatives depend largely of the availability of healthcare services, good salary, income, basic food, nutrition, food security, and the availability of vaccines and medication for the basic preventable diseases and the communicable diseases. So we do know that it depends largely on where you live. We do know then for children, it changes a little bit the concept of health, because it's a moving target, right? Children are growing, and as they're growing, we have to understand what are the different variables that will influence their health. And again, thinking of knowledge translation, which I know you talked in the previous webinar, we have to think what is the knowledge that we are trying to have, that we are then trying to translate. And that's why we are going a bit in depth into the definition of health. So we do know that for Canadian children, when we compare to rich countries, Canada has been consistently in this middle level ranking on its scores for both material well-being, so being 15 out of 29, education, behavior and risk-taking, housing and environment. And most concerning is that our children, that's Canada children, all children, not children with disabilities specifically, but Canada is among the unhappiest children among the high income countries. So 24 out of 29 consistently in the ranks, that's the report card 11. There's a new report card from UNICEF, but Canada is still stuck in the middle, and that has been consistent over the years. When children are asked, are you happy with your life? They are really low, scoring low in comparison to other countries on the same income category. So health for children means largely feeling happy. And what are the things that you need to feel happy according to the UNICEF index? It is really access to education, access to healthy breakfast and fresh food, access to active transportation, vaccination, and active physical activities. So those are the elements that we know. So in Canada, in our own reality, we could and we have to work. That's the type of knowledge that we have to know more about so that we can translate it to better health outcomes. Now, when we think of children with disabilities, there's less data. This is data, and just now there's a new data. I need to update the slide, but it hasn't changed too much the proportions. But for children with disabilities in Canada, and that's the data from 2006, we know that they have chronic conditions, like we have a high percentage of children with chronic and developmental conditions. And we know that their disability has a direct impact on their family life, on the types of, so parents have to work fewer hours or change working hours because to manage or to be able to manage their child disability, or they decide not to take a job, they quit paid employment, or they're turned down a promotion or better opportunities because of their child disability. So for children with disabilities and their families, health is something that they have to fight for their entire life. Is not something that is easily had. We know that children with disabilities participate less in physical and social activities than their same age peers. We know that they spend more time in sedentary activities than other children the same age. We know that they have fewer social networks and networks of supports for their families as well. They face more barriers in the environment to assess diverse activities, health, education, employment for youth. We know that their families have a lower income, and in great part due to to the disability of the child. We also know that they have more higher incidence of mental health conditions and cardiovascular health conditions, especially and often due to a cycle of deconditioning. So they do less from the beginning, and so that accumulates into a cycle of deconditioning over their life course. Now, we do look at health then as a notion of rights. We think that children should not have less health, or children with disabilities, they have the same rights as other children to play, to have access to rest, to recreational activities, to cultural life, the arts. The Convention on the Rights of Persons with Disability also has a specific article on children, and other articles that ascertain their right to participate. So health is a human right, and so is the access to knowledge, and to knowledge that promotes better health. So we have frameworks that exist, like the Sustainable Developmental Goals, that have that promote specific concepts that are about health and that we could apply for communities, right? If we think again of knowledge of health, the knowledge of health goes beyond the walls of hospitals or the spaces where we traditionally grouping health, and extrapolates to what's happening in the community. So we know that the social determinants of health and the Sustainable Development Goals have aspects related to good health and well-being, reducing inequalities, sustainable cities and communities, and partnerships for the goals. And also we have the notion of preventing to promoting health, right? So all those frameworks like the ICF, the WHO ICF, they will speak to the idea of we are no longer trying to prevent death. We are really trying to promote health in an all-encompassing way, in a way that includes activity and participation, that takes into consideration environmental factors and the personal factors related to the child. And all of that should be part of our toolbox of knowledge that we want and can do something about and act on. So from promoting individual health for people to really trying to create healthy cities, that's the type of knowledge translation then that we're trying to migrate here or to talk about today. So the community wellbeing framework is a framework that was created based on large body of systematic reviews, looking into what promotes well-being. And going back to the UNICEF report card, we know that for children in general, but well-being or happiness depends on what you call and depends on the measure that you use. It really depends on all these factors, right? So specifically, I'm highlighting some support systems: mobility, resilience, complete community, play, sense of ownership, collaboration. All those aspects are aspects of health that we don't talk too much when we are developing our research studies or when we're developing our health interventions, but they're really, really shown. There's lots of research showing that they are fundamental if we want to create this notion of health as part of cities, as the way we conceive cities, communities, and public spaces. So with this in mind, I'll speak to some of the projects and what are the knowledge translation strategies that we have used. Hopefully that we have some time to discuss, and how do you see this applicable to your reality. Those studies were basically based on initial studies showing we wanted to identify barriers and facilitators for the health and well-being of children with disabilities and their families. We wanted to engage a diverse group of stakeholders. So going back to this framework, this idea of collaboration is so important, and the sense of ownership. So stakeholders would including healthcare providers, education professionals, community workers, policymakers at different levels, families, youth with disabilities, and the researchers, all around the same goal. And to test solutions to promote participation, health, and the human rights for children with disabilities. So one of the first studies that we did on this line was asking families in Quebec, families of children with cerebral palsy, asking how they located or how was their participation in leisure, what did they do, where did they go to find information, and what are the challenges they faced in trying to find opportunities for participation in leisure in the community where they lived. So most families go online, and in this study, parents said repeatedly that finding activities that are suitable for their children, that are close to where they live, is like a detective work. That they have to go to 10 different places before they find something that is marginally suitable. When they find, often is not close to where they live. When it's close to where they live, it's not what their child wants to do. So there are several challenges there, but they still rely on word of mouth from clinicians, from teachers, but from the city guide less, but largely online. But interestingly, when we ask about the big challenges, so we ask, often we think of income as being a problem because adapted activities are often more expensive. But most families said that they perceived that their income was sufficient to help their children do what they wanted to do in terms of leisure. However, the vast majority, 82% of the participants in this study said that they did not know about information related to leisure, and that was more of a problem. With that in mind, we brought together, as I said, a group of stakeholders across different cities in Montreal and in Canada to identify, so what do you have to say in terms of leisure promotion? What could you do? And that's the first knowledge translation project that I worked. That was a good 10 years ago. And what we did is, like, at the time it was not called integrated knowledge translation. Now it's what I would call, but essentially we really brought stakeholders from the different sectors all together in those different forums, and we prioritized solutions. We presented the research. We said, these are the barriers which you all know. Now, how could we practically do something about it? What could we do that is actionable, that could translate this knowledge into something concrete that would help children participate more in leisure? What are their priorities, and how would they go about? Because in research, we often have this challenge of getting things into action, and we do generate a lot of knowledge, but the knowledge to action is more of the problem. From these forums, so from the active participation of stakeholders, we identified those priorities. First was to create a list of resources. So they said, if only we had a place to go where we could consult and look, hey, this is activity, this is where we could go, it would be great. The second was to create opportunities for peer mentorship for both parents and youth. So opportunities to talk to other parents, with other clinicians, with other educators, about ideas to do leisure activities that are inclusive, or how we could do that. Also to generate school-based programs, because they said often children are in school, but they cannot participate in the after-school activities, for example. And also to talk to policymakers, because a lot of the participants in this knowledge translation workshops, they said, well, it's great, we know the information, but we don't have programs that are available. We need to talk to the decision makers, to the people who can do something about it at the larger level. So with that in mind, we started to think what would be solutions. And one solution would be to do an app. So we know this number is actually probably outdated. There are more than that, I guess, Canadians who use a smartphone. There's a lot of research actually done talking about mobile health, is what we called, and the use of apps to promote health in different ways. But we can also think of apps that are used to promote leisure. And I guess everybody, if I were with you live, I would ask you to raise your hands or Zoom hands, but we don't have this. So I was going to ask who uses Yelp, for example, to find restaurants, or TripAdvisor to find places to travel information, Strava for running or for motivation, for group peer mentorship if you run, or there are many other apps that for running, Tinder for company, I guess, or for peers, for locating, for matching, or finding some sort of leisure in this way, Spotify for music. And what all mobile health or mobile apps promote is the ability to have choices. So that's very important for health. And that's an important piece that I would like you to remember. Opportunities to have choices is something that children with disabilities often don't have, to make choices, and their families also cannot make choices. It's like, oh, we have this program, it's give it or take it. It's all we have. Either you do this or you do nothing. And that's important thing if you think of your own life. And that's what research says, that that's something that mobile apps can do. Promote accessibility. So almost everybody has access to something on their phone. If it's free, it's affordable, it's practical to use. It can be fun. Many apps have games and rewards and opportunities to comment and interact with others. And so that's, with that in mind, we created the app Jooay. So that's the little advertising moment. Go and download. Jooay is a free mobile app that was created as our main knowledge translation product, Dr. Annette Mainmer and I. So we created this app that is free for use, and that is a growing list of resources, right? That has solutions at leisure activities, arts camps, sports, and others like movie theaters, playgrounds, respite care for families. So, and especially that creates an online community of support. You should all download, tell your clients, patients, research participants if you can. As I said, it's free for use, and it has a really growing, it depends on crowdsourced data to grow. So the more people use, the more it gets efficient. It is really a collaborative team. So in terms of practical knowledge translation projects, this is a research team that has parents, that has people from the community, that has people from the online industry world, that has people from the school sectors, so the education sector, and teachers, phys ed teachers, therapists of all sorts, OTs, PTs, recreational therapists, and decision makers in different ministries across provinces, to really try to find, okay, how we can then have this information, but use this information. A large team of researchers and parents and a bunch of people that help. The target audience is parents and youth and healthcare professionals and educators. It's kind of half and half. The majority are parents, but a good 35% are educators and healthcare providers who use the app to help the families that they see to find activities and solutions for health promotion in the community, for them to participate in soccer, dance, yoga, camp, painting, piano classes. We have more than 3,000, now we have more than 4,000 users. I just realized that this number is not super up to date. We have active users each month, more than 100, and we have more than 300 sessions. So it's something that is recurrent use. Not yet the 800,000 children with disabilities in Canada. Hopefully we continue to increase these numbers. As I said, we ask people to identify who they are, and we have a good distribution of all different users. So based on that, we come back to then, okay, what is knowledge? This is health, right? This is a solution to promote health. This is a knowledge translation project. I'll say entre guillemets, quote unquote, because it's really, it became a buzzword, knowledge translation almost, but for me and for the team, this is a definition that we kept working on and building on as we took information, knowledge generated in research, and transformed into action. So we translated it into a mobile app, and that was our example of health knowledge transformed into health action, or knowledge to action. But then if we think of knowledge only as what comes from research, that's limited, right? Because it could really come from different sources. So I'm sure you've seen on the series, the knowledge to action framework. So there's knowledge, a lot of knowledge comes in all the different squares here. So knowledge inquiry, knowledge synthesis, knowledge tools, we identify a problem, we find the knowledge gap, select the knowledge. But in all of this, what are we calling knowledge changes what we do in the next step, right, of the cycle. So with this in mind, the same way that I think it's important that we expand our notion of what is health, I think it's crucial that we expand what's our knowledge, our notion of knowledge is. So using the example of the Jooay app research, we started to explore a little bit of what are other sources of knowledge that we should consider. So for example, information that comes from the communities that were formed through the app, but on Facebook, on social media, for example, that was one source of knowledge. We also could use the knowledge that came from the app itself. So data, like we are all selling our souls to different apps. Luckily, we have very strong ethics into the all reviewed by the ERB to have access to limited information from users, but we can use a certain level of information to actually use this as knowledge that we can act on. So through the use of the app, we can identify some of the users' needs. What are they searching more often? What do they would like to find? What are they searching that they're not finding? And we can identify patterns of use to use this as a knowledge mobilization strategy. So to help them find more the information, and hopefully by having the information, being able to access the activities. We also use knowledge that comes from the community organization. So that's a new type of knowledge that we are learning how to use more or to solicit more. So we have community engagement strategies that we go into the places, we ask the people, what do you want to know? What is the information that you need to know? And a lot that came from this was, for example, communities identified, municipalities like a ministry of families in Quebec they were developing a strategy for child-friendly cities. And the question was like, okay, if we need to consider child-friendly cities, do we need to add specific details for children with disabilities? And yes, we did. The city of Montreal is working on a new strategic accessibility plan for the next 10 years. We did a systematic review to inform what are the strategies related to accessibility that should be considered. So knowledge comes from communities, from government, and comes to us researchers as an opportunity to generate more knowledge and to translate it back and forth. So the translation comes from an ask, right? The knowledge is like, what do we do to create an accessibility plan? And then from us, the translation is, here's the research. That's how you could use, or those are some ways to identify those needs. We also could map inequities in service provision. So we look into material and social deprivation across Canada and how that related to the offer of leisure activities across the different big cities, Toronto, Montreal, Calgary, Vancouver. And with that, we generated policy dialogues where we brought in policymakers to say, okay, here are some issues that we identified. What could we do to resolve those issues, and partner with cities, with governments, with ministries to help them organize the information coming from different sources into possible action plans. And also to respond to the needs of users. So during COVID, we had to adapt the knowledge that we were receiving and that we are putting forth. By including, for example, on Jooay, online activities, so activities that are offered online and that the families then could access. We had to change the interface to add an online category to the app, and that was all done. Again, it's a knowledge exchange where we are listening to the needs of the community, considering this as a serious source of knowledge, then trying to see what's the research or academic-based knowledge that we have that can help inform that, and then bring it back to the community and then assessing how that works. So knowledge can also come from the individual's actions, right? So that's the health behavior framework where there's a lot in here, but one important aspect of health behavior is that health behavior generates information that is knowledge that we can use to then translate it back to the community, right? So we did this feasibility study using using the Jooay app, and we looked into who they were, where do they live. Most people live in urban areas, and for whom they were searching activities for. So with this information, we know that most parents are looking for activities for their school-age child, 4 to 12-year-old. They want to be able to track activities in the community where they are. So with that in mind, we added some elements, and we'll add some more elements of interaction with the app, where when you're looking for an activity, it gives you more information about that type of activity so that it's even easier to find. And hopefully what we hope is that this will change the behavior, the end behavior of participation by retrofitting what they need to do and how they can find this activity more easily and then help their child participate. Knowledge also comes from systematic reviews, and perhaps this is the more traditional source of knowledge that we're used to. That's what we call, when in the middle here, the knowledge synthesis part. But systematic reviews are not, we can use systematic reviews to inform things like a course of action for an intervention, or for developing a specific program, or for governments to fund one strategy over the other. But we can also use systematic reviews to compile a broader understanding of health and interventions, like the community wellbeing framework. So use knowledge coming from systematic reviews to say, what are the specific or most important outcomes that we have to promote, or that we should promote in our interventions? And then design interventions that include those political, social, environment, economical, cultural aspects of health. And this is, for me, another crucial opportunity for knowledge translation, which is really, again, enlarging the scope of action of what we do. Then the last piece of knowledge that we also consider is that knowledge comes from the reality, right? So the reality, what's happening in the political life, in politics, it's the war in Ukraine, it's the COVID-19, it's all of this is generating knowledge. And this knowledge, if we take it seriously and we analyze and we treat it as an equal source of knowledge as our research studies, we can then create and work on it and feed it back to the public by doing something. For example, something we've been doing is the policy dialogues in leisure promotion. We did in Vancouver, did in Montreal, we did another one online during the pandemic. But the main factors contributing to the creation of inclusive programs, we could highlight that those came from the community. We asked community organizations, and then we found the research evidence that would match what the community was saying. And we combined those to tell policymakers, this is from two different sources of knowledge. That's what we believe could be done if we want to promote leisure for children with disabilities. So, for example, capacity building, train professionals that are working in the community about disabilities at large, so that they are prepared to receive and to interact and to design programs for these children. Accessibility of facilities, funding models that accommodate for ongoing activities in the school, in the community, and creating collaborative networks. For me, a great example of knowledge translation we had in BC, in the policy dialogue we did in BC a couple of years ago, was that there were a ministry and another department within the ministry, but they were both doing a list of adapted inclusive activities, but they hadn't talked to each other yet. And it was during the dialogue that they had this opportunity to say, hey, we're working on the same thing from two different spaces, but towards the same goal, let's get together. And sometimes it's something simple like that. We also did a policy dialogue focusing on rights, human rights-based approaches in Ottawa, and that included all the federal and provincial and territorial partners and government and civil society organizations to inform evidence policies. Another example of knowledge that comes from the reality, but from other realities that we don't always access or that we're not always looking for, is what international agencies like the WHO, the United Nations are promoting. So the WHO has launched this urban health agenda for 2030, and it really has an intention, or has a very good, well done document reviewing ways to promote health equity and collaboration in the cities to promote health from the bottom up. And they are talking about, I love this word, they're talking about creating a collaboratorium. So where research, healthcare providers from different areas, educators, community come and collaborate in generating knowledge that again informs multiple streams of action. The United Nations Convention on the Rights of Persons with Disabilities and on the Rights of Children. Those are two international treaties that are valid and ratified in Canada. and that have an ongoing reporting system that also generates opportunity for researchers, for healthcare providers to give an input. So we participated in the first revision of the UN CRPD, the Convention on Rights of Persons with Disabilities. There was a realization that there was absolutely no data on children, and that's how we had the opportunity to go to the UN multiple times now and speak on behalf, or not on behalf, but about children with disabilities to the UN, which then became a document that is called the Concluding Observations to the Government of Canada, that eventually becomes local policy, such as adding better data collection in the Stats Canada and the census, which was done in the last child health survey, talking to the Ministry of Disability and taking youth and their parents. That's Leon is a youth with autism, and his mom and another mom of another child, Rachel, who went to speak with us at the UN to say what are the lived experiences of people with disabilities and children, and what are the actions that governments can do together to try and change that. We're trying to work at CHILD-BRIGHT. We have the policy hub that is in the strategy to bring together research, parents, families, and policymakers, and strategize opportunities for exchanging, to participate in the different UN reviews, but also to interact as a civil society and advocate for the rights of children. We also identified knowledge, as I said, that comes from emergencies. So what's happening in the world should be a source of knowledge that is worth translating somehow. And we reviewed that through looking into different agencies' documents and how the policies that were produced during the pandemic, both international and in Canada, responded to the needs of children with disabilities, also contributed to the WHO Global Health Global Report on Disabilities, and other projects looking into mental health policies during the COVID. And we used a disability framework, a human rights framework, to analyze this data. And we are now producing documents for parents to understand and use this information to advocate for their children, but also for governments to see what are the rights-based approaches that they could incorporate into policies, and how they should be, how they were lacking during the COVID pandemic, but also how they can be promoted. Creating support systems, I think it's really essential, an essential part of knowledge translation. There's no knowledge and no translation, and hope to have built this point, that can be propagated or that can be mobilized in any way if we don't have strong collaborations. Families of children with disabilities have said that extensively, how support systems are very important to understand, to have sources of knowledge they trust, and that then can be used into their practical life. So we have created that through Jooay, what we call the Community Connecting to Play, through the CHILD-BRIGHT Policy Hub, the Citizen Engagement Council, and other KT and integrated KT initiatives. Some cultural aspects we have also I think it's fundamental for knowledge mobilization, knowledge translation, to be able to talk to people outside our regular systems of care. So we've been talking to cities. It started with the playground at the MAB Mackay School, but now we're talking to Côte-Saint-Luc, Westmount, Rosemont-Petite-Patrie. There are different municipalities now that want to build inclusive public parks, inclusive playgrounds, and they're always coming to us. And I have a student who just defended his thesis last week, who developed a community health inclusion index for children that has a part specific for playgrounds. We also participate in initiatives related to physical activity promotion for children with disabilities, and with real community partners like the Blue Jays, Earth Rangers is another community partner, Canadian Coach Association. So really building this cultural vitality aspect by including diverse communities into the knowledge generation. So if we go back to the knowledge to action cycle, knowledge generation, identifying, adapting knowledge to the local context includes talking to people that are the context, right? And that's the way that we have to expand our scope of knowledge translation actions. We are working with, as I mentioned, so different increasing service provision, so the economic aspects, looking to the social material deprivation, but also the affordability of spaces and strategies and how they can be implemented. And hopefully with these initiatives, I guess there's no real worth of knowledge produced in academia or otherwise that will have an impact if we don't work with, if we're not aware of how it can go or what it can do, right? I think knowledge for itself to publish in a scientific journal or whatnot is really not the mission of what we want to do. It's really what we want to do is, we know that equality, equity, I use this image so much since I found it because I think it's really powerful, and I'm sure you've seen this before. We know that it's not sufficient to provide the same for everyone. We know that equity, providing what everyone needs, is good, but in reality, and that's where I would see children with disabilities, and if you add other layers of intersectionality, so for children who have disabilities and their families are in other intersectionalities, like girls with disabilities, LGBTQS, if we have immigrants, there are so many other layers of reality that make equality impossible. And so they call it liberation in the real image, but I change it for universal accessibility, but it can be equitable knowledge translation. We can use a lot of words, but where we're really trying to act on, so for me, the big action for our knowledge is to remove those barriers in all different sectors and across different layers of knowledge. By respecting, understanding, considering, and incorporating into action plans so that everybody can enjoy and we can level the playing field, right? So what is knowledge and where do we find it? Hopefully this short talk, and I realize our time is up, that it's really everywhere and it's being produced in the different spaces that we're living. It's important that we pay attention to it so that we can translate it properly and in collaboration, in partnership with everyone around us. Thank you so much. Hopefully we have some time to talk. We still have 10 minutes, okay, to discuss. So I'll be happy to take any questions. Do go download the app. Look at childhooddisability.ca. We have a lot of also lay summaries related to different disabilities and policies, and a lot of the knowledge translation work is there as well. Thank you.
Thank you so much. That was very interesting. I think very, well, at least from my perspective, very different. I do a little bit of advocacy, but I think that we really get a bigger picture of knowledge to action. You know, I do some advocacy, but not as much as certainly as you do. What would, I can ask the first question and maybe Amira can see if there's other one. I'll just see. I was just wondering, what is your biggest, I would say, so you get different type of children with disability, which is one of the things that we have also in the neuromuscular field, because we've got different diseases that are all rare. Mm-hmm. We've got adult and pediatric. What is your biggest challenge in terms of trying to be inclusive of all that diversity of pediatric condition? And you talked about parents' condition and living in an urban city or in a rural city. How do you look at this?
Yeah, that's a great question. It's such a challenge. I think so. What I'm trying, so when we're talking about policies, it's tricky, right? Like a lot of my knowledge translation work is in policy, and because policies are all encompassing, right? There technically shouldn't be a policy for this condition, right? It should be a policy that helps a majority of people, and that's how public policy should work. But we do need also to name things. There is a need, the way things are, right? Like, so for example, I was working now this year on the knowledge translate, on the evidence-based committee for the National Autism Strategy, right, that Canada is developing. And throughout this issue of like, how do we include other conditions, it came on and on, because is it fair to develop a policy for autism, and who is left behind, right? Who is not included in an autism strategy that should be included? Why are we creating an autism strategy, not a disability all-inclusive? So it's an ongoing challenge. I don't have a good answer, but what we do try to do is to represent, so in all the stakeholder groups that when we're talking about human rights, for example, we have really representation from a diverse group. And so in the UN convention, for example, we have civil society groups that are like adult conditions, dementia, deaf blind, developmental disabilities, autism. So we try to really include as many representatives of conditions as possible. And then when doing research projects, so when you were trying to select, often many of the research I showed was for like CP or autism, or that's a kind of feasibility issue for the research. But when we are doing the translation part, we try to think, okay, so what are the considerations that would be good for everyone, right? What do we need in terms of services that everybody could benefit from? What families need? And when families have disabilities themselves, what else do they need? What extra support? So I really think it's by having people on the table all the time, as much as possible, is the best way to learn about how to include more people, right? And thinking critically, like who is not here. That's an exercise that I'm trying to do more and more. It's like when you're sitting in any advisory council, committee of something, or research of anything, try to think who is not here and how do I go about getting them. And that's an ongoing challenge. But I think if we keep that active, is the best way. And then eventually you start to have more and more partners and increase the fold and representation in consequence.
The question that we see in the chat is, you mentioned the importance of partnerships. And one question here is, how have you incorporated or worked with patient research partners in knowledge translation plans?
Yeah, so much. So all of this work that I presented was all done with patient partners. I personally don't like the patient partner designation, but it's, so I'm on CHILD-BRIGHT, right? CHILD-BRIGHT is a strategic patient-oriented research network. And I'm co-leading the knowledge translation program of the network. The whole network is based on patient partnerships. So I have a co-lead, the KT committee has a co-lead who is a parent, and we are really co-leads, like we have weekly meetings. We develop a very strong structure for compensation. I think that was an important aspect of governance that you cannot forget, and that we absolutely, if you want to include patient partners, you should genuinely budget for it from the beginning, right? So CHILD-BRIGHT has a citizen engagement council, and we have developed a very strong patient compensation guidelines with hours, and there's a terms of reference that people sign. It's a serious business to be engaged in different research projects. And the premise that you have to know that there are a few lessons learned in the past 7 years, that it takes time, and you need to take the time, right? You need to make sure that you explain things, like the example I always tell is like one of the parents in the KT committee on CHILD-BRIGHT, like after a few meetings, and the committee is like, healthcare providers, parents, other people. And then they texted me on Facebook, and they're like, Keiko, I have a question. When you say knowledge translation, what do you mean? And that was after a lot of the KT committee meetings. So we do have to take the time to, explain the concepts, to know that the vocabulary, the things we talk are not a given. They have other knowledge that we have to also learn to listen. And all of that takes time, right? It's all relationship based. I think we have to be willing to take the time to compensate financially for the time to take the provisions. If you need caption, if you need sign language, if you need whatever you need to have people in participating actively and meaningfully, but mainly developing like the trust relationships. I think the best patient partner collaborations are done in trust and based on devoting the time it takes to any relationship, because that's when you get the real exchange space and the real benefits. So I think that's, yeah, but all of it is done. Like I don't have any projects that don't have patient partners, and they're just partners.
Very good. And then the next question here is neuromuscular disorders are sometimes rare and ultra rare, which adds its own level of barriers when introducing these types of KT plans. Can you speak to any strategies? This individual is just commenting that oftentimes the KT activities don't focus on policy because the focus is even around knowledge uptake at the clinician level. So how can you move that forward for rare neuromuscular diseases?
Yeah, excellent point. Yeah, for rare diseases is, I think the challenge is in a way the same for everyone, right? Like you have to find where people are, what are their needs, and develop those collaborations, like with patient networks. Even the rare diseases, I know of a few networks, I'm sure you are all aware, like on Facebook, like the majority of the parents I collaborate with in any projects, they're really active on Facebook. They know who to talk to, right? So parents especially, they are ultra motivated to find the people who they need to talk to, right? Sometimes they just don't have the channel or the voice, the validation of a researcher or someone to back them up. But once you find them, you can really go a long way because they know the channels. And I think that's the fine line between KT and advocacy even. So on the other part, so I think first finding, so to the first part of the question, finding people, I really think it's the network forums, the parent coalitions and groups, try to find who are the parents who are there and who are already active, because they can lead the way to pulling in or bringing the other people. Now for the policy, moving from clinical, yes, we do often focus KT on the clinical and less on policy, but I think that's the next step, right? And that's the step that parents are also willing to help. And advocacy groups, they know, talk to their MP. Like sometimes it starts little and it really grows, right? Identify your MP, send a letter, try to see who in the local, in the local writing has an interest on that. And then start these conversations. It's really less scary than it looks. I think like when I began talking KT to policy was like, what? Now it's really growing. And we know, like once you start talking to people, they will tell who else more. And if you purposefully shape your KT strategies to include policy, you can also have them on your table and say, that's what we need. And then the conversations start. And it's not a simple answer.
Now it's time to wrap up. Thank you so much, Keiko, for your wonderful talk. We're very happy to have you and to learn more from a very active KT researcher. And I just want to people know that we will have another KT webinar somewhere in September or October. The date is not final. So we will talk about implementation of knowledge, because you can translate it, you can put it into action, but then the last step is to make it, so that people use it. And so thank you so much. And hopefully we'll have you back somehow, somewhere, and we'll make sure that we promote that app for our children with disability.
Thank you. It's my pleasure. Thank you for having me.
Bye.
Bye.
Thanks, everyone.